Good evening, one and all. On behalf of Dr. Agarwal's Institute of Optometry, I extend a warm welcome to each and every one of you for the 13th episode of brand new Optometry Series 2.0. I'm very happy to welcome my team members, Ms. Anshika ma'am and Ms. Meenakshi. Hi, both of you. Thank you so much for joining and thanks for your support throughout the Optometry series. I'm very happy to welcome our moderator for the day, Ms. Susan ma'am. Hi, Susan ma'am. Thank you so much for joining with us today, ma'am. Now over to Anshika ma'am. So Anshika ma'am, please let us know what is today's topic and more about the moderator ma'am.
Thanks, Gomati. Today we're going to know about anterior and posterior chamber angles and the diseases in them and about the structures. Thank you, Susan ma'am, for agreeing to be a part as a moderator. I know Susan ma'am from the time I was working at Shankar and we used to report to her. So it was very nice to get back in touch with her. So thank you so much, Susan ma'am, for accepting our today's invitation. I request the MC to please introduce Susan ma'am.
I'm Mahesh, 18 batch. I'm I'm really glad to welcome you to today's session of our YouTube series. We have a wonderful session lined up and lead it. We have to with us moderator Susan Mathew. Ms. Susan Mathew is an associate professor in the Department of Optometry at the Medical Trust Institute of Medical Sciences, Kochi. She holds a master degree in optometry from the Kerala University of Health Sciences and a bachelor degree in optometry from the School of Medical Education, Little Flower Hospital, Angamalai. With over 8 years of teaching experiences and 11 years of clinical experiences at Sankara Nethralaya High Hospital, Chennai and Greater High Hospital, Kochi. She brings immense knowledge and experience to the field. Ma'am also serves as a nodal officer for the student support and the guidance program, an initiative by Kerala University of Health Sciences and supports and mentors students. Ma'am also presented research at the Second World Congress of Optometry held in Hyderabad. We are truly delighted to have with us, ma'am. Thank you for joining, ma'am. The The presenter for the today is Ms. Keziya, studying second year Masters in Optometry at Dr. Agarwal's Institute of Optometry. Ms. Keziya, start your presentation.
We'll start with the anatomy of anterior chamber. The anterior chamber is a space between the cornea and the iris, and it is bounded anteriorly by the posterior surface of the cornea, and it is bounded posteriorly by the anterior surface of the iris and a part of the ciliary body. So the average depth of the anterior chamber in normal adults is about 3 millimeter. So it is comparatively shallow in It's comparatively shallow in very young children and in elderly individuals. So the depth of the anterior chamber is genetically determined with the dominant mode of inheritance. So anterior chamber contains approximately 0.25 liter of aqueous humor. So the anterior chamber communicates with the posterior chamber through the pupil. So at its periphery, the chamber forms a recess known as anterior chamber angle. So the angle of anterior chamber is mainly formed by the trabecular meshwork, which plays an important role in aqueous humor drainage. So when you perform gonioscopy, the structures seen in the angle from the anterior to posterior are Schwalbe's line, trabecular meshwork, scleral spur, ciliary body band, and the iris processes. So first, we'll see each one in detail. So Schwalbe's line. Schwalbe's line is the most anterior structure of the angle, and it appears on an opaque line demarcating the peripheral termination of the decimus membrane, and it marks the anterior limit of the trabecular meshwork. And trabecular meshwork extends from the Schwalbe's line to the excleral spur and is about 600 mm in width, and it has ground glass appearance and appears to have a depth. It also contains two main parts, anterior non-functional part, which is non-pigmented one. It lies adjacent to Schwalbe's line, which is whitish in color, and another part is the posterior functional part, which will be pigmented. It lies adjacent to a scleral spur, and it appears grayish blue and translucent. So the trabecular pigmentation is rare before puberty, and it increases with age, and it is more pronounced in brown eyes, especially in the inferior quadrant. Next is this scleral spur. The scleral spur is the most anterior projection of the sclera, and it serves as this attachment site for the longitudinal fibers of the ciliary muscle. So when you look to gonioscope, it appears as narrow, dense, and shiny whitish band located immediately posterior to the trabeculum. So it is an important landmark because it has a consistent appearance across eyes. So next is the ciliary body. So the ciliary body lies just behind the scleral spur. It visible as pink, dull brown, or slate gray band. So its width varies depending on the iris insertion. So it will be narrower in hypermetropic eyes, and it will be wider in myopic eyes. So the angle resist represents the posterior dipping of the iris as it inserts into the ciliary body. And we have iris processes. So iris processes are fine extensions from the anterior surface of the iris, inserting at the level of scleral spur and something converting part of the ciliary body. So they are seen in about 1/3 of normal eyes. So it will be more common in children and in brown eyes. So with age, the iris processes thin out and it may disappear. So let's see anterior chamber grading. So in grade 4, the ciliary body will be visible, and it is the widest angle, and it is incapable of closure also. And in grade 3, the scleral spur will be visible, which will be open angle, and here also it has incapable of closure. And in grade 2, only trabecular meshwork will be visible, and it will be moderately narrow, and the closure will be possible here. And in grade 1, Schwalbe's line on top of the trabecula will be visible, and it will be very narrow, and the closure is also possible, and here it is at the highest risk. And and in the slit, there will be no distinct structures seen, and there will be no iridocorneal contact also. So mostly it will be closed. So here the greatest danger of imminent closure also possible. And at grade 0, there will be iridocorneal contact and no corneal wedge apex will be visible. So the angle status will be closed. So there will be complete closure of the angle. So in order to see this, we need indentation gonioscopy to view the closed angle better. And next we'll move on to the posterior chamber. So the posterior chamber is a triangular space located behind the iris and in front of the lens. It contains about 0.06 milliliter of aqueous humor, and aqueous humor is freshly secreted by the ciliary processes into this chamber. And the anterior boundary of the posterior chamber is formed by the posterior surface of the iris and a part of the ciliary body. And the posterior boundary is formed by the anterior surface of the crystalline lens and its zonular fibers. So the lateral body is formed by the ciliary body. So the posterior chamber is a part of anterior segment of the eye. It is located between the iris and the anterior surface of the lens and the zonules, and it is divided into 3 compartments: prezonular space, and retrozonular space. So the location of the prezonular space will be, it lies between the posterior surface of the iris and the anterior surface of the zonular fibers. So the space immediately behind the iris and in front of the zonules. So the zonular space centrally, it be located in the centrally equator of the lens, peripherally the ciliary processes, anteriorly the ciliary processes, and the posterior surface of the anterior zonular fibers, and anterior surface of the posterior zonular fibers. So the space that surrounds the lens equator contains the zonular fibers. And next is the retrozonular space. It exactly lies between the posterior surface of the zonules and the peripheral part of the anterior vitreous space. So it located behind the zonules, that is near to the anterior vitreous surface. So next is the aqueous outflow. So we have two pathways, trabecular pathway, which is conventional. So it contributes about 90%. So the flow sequence will be a trabecular meshwork, then it travels through Schlem's canal and via collector channels and through aqueous vein, followed by episcleral veins. So in juxta-canalicular meshwork, it is located adjacent to Schlem's canal, so it will be the main site of resistance to the aqueous outflow. So this route is pressure dependent. That means it is affected by intraocular and episcleral venous pressure. And next is the unconventional pathway, that is the uveoscleral pathway. It contributes about 10%. So the flow sequence will be, it starts in the ciliary body and goes between ciliary muscle bundles via suprachoroidal space and then followed by sclera and venous circulation. So this route is pressure independent and it provides an alternative drainage pathway. So next we'll see about the factors that influences the aqueous outflow. So firstly, the integrity of the trabecular meshwork. Secondly, the composition of the extracellular matrix. Thirdly, the age-related structural changes. And finally, the episcleral venous pressure. So next we'll move on to the anterior chamber diseases. Firstly, we'll see about anterior uveitis. So anterior uveitis is the inflammation of the uveal tissue from iris up to pars plicator of the ciliary body. That is the anterior uveal tissue. So you also have iritis, in which inflammation predominantly affects the iris, and iridiocyclitis, in which the iris and the pars plicator part of the ciliary body are equally involved, and we have anterior cyclitis, in which the pars plicator part of the ciliary body is predominantly affected. So symptoms include for the maybe acute or chronic in presentation. So the patient may experience ocular pain. So the pain might be dull, aching, throbbing. It worsens at night and it radiates to forehead and the scalp via fifth nerve. So next, the patient might present with redness. So that is a circumcorneal congestion. It is due to dilated anterior ciliary vessels. And next, the photophobia and blepharospasm. So it'd be due to reflex from the irritation of the trigeminal nerve. And next, the patient might experience a lacrimation. So it is a reflex tearing through trigeminal and facial nerves. So the patient might experience decreased vision also. It's from the ciliary spasm induced by myopia and corneal haze, aqueous turbidity, and there will be pupillary block, and there will be cataract, vitreous haze, macular edema, or secondary glaucoma. So on slit lamp examination, when you view lids and conjunctiva, so in the lid there will be mild edema. So in conjunctiva there will be circumcorneal congestion, also known as ciliary flush. So it's marked in acute cases and it is minimal in chronic cases. So when you look at the cornea, so there'll be corneal edema. So it is due to endothelial damage or due to raised intraocular pressure. And we have hallmark sign of anterior uveitis. So that is keratic precipitates. So keratic precipitates is the hallmark sign of the anterior uveitis. So we have different types of keratic precipitates here. That is a mutton fat keratic precipitates, which appears as large, greasy, and yellowish in appearance, and it will mostly seen in the granulomatous uveitis. So next we have small or medium keratic precipitates. It's only seen in the non-granulomatous uveitis. And next is the fine or stellate keratic precipitates. It's maximally seen in the futures heterochromic iridocyclitis and viral uveitis. So lastly, it's old keratic precipitate. It appears faded, pigmented, and mostly been irregular in shape. So anterior chamber changes. So we can able to see aqueous cells and flare. So it is due to Tyndall phenomena. And we have hypopyon. So that is a collection of pus in the anterior chamber. And we have depth changes, that is shallowing due to posterior synecdoche, that is iris bomber formation. And in iris, uh, there'll be loss of pattern, so it be due to edema or atrophy. And color changes, it will be mud in color, which is active. And in the chronic conditions, we can able to see atrophy. So iris nodules, we have Kopay nodules and Sacca nodules. So Kopay nodules, it be in the pupillary margin, and the Sacca nodules will be in the collarate region. So next we have posterior synecdoche. So posterior synecdoche is the adhesions between the iris and the lens. So it'll be either segmental, annular, or total. So next we have a classic sign of iris. So rubiosis iridis. So here there'll be new vessel formation on the iris. So it'll be seen in the chronic cases. So these are the pictures I've inserted for each sign. So pupillary changes. So in pupil will be meiotic and irregular because due to the posterior synecdoche, and pupil may appear in festooned pupil. So it is the irregular margin seen after a partial dilation. There will be ectropion pupillae, that is the eversion of pupillary margin caused by fibrin contraction. So the pupils will be sluggish to light reaction, or it be absent because of the iris edema. And next will be occlusio pupillae. It is the total blockage of the pupil by the fibrinous exudate, it by preventing the aqueous flow. And next is the lens changes. So we can able to see pigment deposits on the anterior capsule from posterior synecdoche, and exudate deposits can also be seen on the lens surface in plastic uveitis, and there'll be complicated cataract. It shows polychromatic luster, that is the breadcrumb like opacities in the posterior subcapsular region. So for treatment for anterior uveitis, we have systemic corticosteroids. For severe or resistant case, we can give. So the dose should be tapered gradually to prevent the relapse. And we have non-steroidal medications like aspirin and naproxen. So it is used when steroids are contraindicated. So it will be mostly helpful in arthritic associated uveitis. And next is the immunosuppressive drugs. So it is indicated in the refractory or side-threatening uveitis. It is often used under specialized supervision. So lastly, we can administer systemic antibiotics like azithromycin and tetracycline. It is mainly used in the chlamydial or Reiter syndrome, which is related to uveitis. So physical measures, we can suggest hot fermentation because it relieves pain and it improves circulation. Can suggest dark goggles to be used by the patient to reduce photophobia and to enhance the patient comfort. So normal tension glaucoma, uh, we have myopia of 21 millimeter Hg, and glaucoma's damage will be prominent, and the angles will be open. There'll be a prominent visual field of loss, and there'll be no secondary cause of no secondary condition to be caused. And the exact cause is still unknown. It is assumed to due to vascular spasm or due to any systemic association. So it will there are two types. So it will be pressure dependent or a pressure non-dependent. So pressure dependent will be due to structural abnormalities, and pressure non-dependent due to migraine or Raynaud's. So investigations for normal tension glaucoma. So we have to take history initially. So there'll be routine examination followed by history, and optic nerve evaluation like OCT should be performed, and visual field testing like perimetry should be performed. And we also see systemic vascular risk factors. To in order to check, we have to suggest patient to have blood to undergo blood tests like vitamin B12, blood count, ESR, and plasma protein. And we also suggest patient to take an MRI for further evaluation. And next is your congenital glaucoma. So it is a group of diverse disorder. So abnormally increased IOP will be there. It is due to developmental disorders of the anterior chamber angle, which will be obstructing the aqueous drainage. So it may have ocular or systemic association also. It'll be more 90% will be sporadic in nature, and AL is less common, which is of 10%. So it'll be mostly bilateral. So prevalence will be about 1 in 10,000 child. So this is the pathogenesis. So there will be maldevelopment of the trabeculum meshwork and iridotrabeculum junction, which impairs the outflow, and it causes raised intraocular pressure. And clinical features. So here we have clinical triad, that is lacrimation, photophobia, and blepharospasm, which is a most classical sign in the congenital glaucoma. And in cornea, there will be corneal edema. So the diameter will be more than 13 millimeter, and the tears and breaks will be present in the descending membrane. And in sclera, the sclera will be thin and blue. The anterior chamber will be deep, and iris we can able to see iridogenesis, and subluxation of lens can be seen. And optic disc will be we can able to see cupping of the optic disc and the atrophy also. And IOP levels will be high, and axial myopia may also be seen in such conditions. So these are the pictures. So there'll be a cloudy cornea due to forceps injury and dystrophies. So large cornea, that is megalocornea due to myopia. And lacrimation, we have nasolacrimal duct block and aberration and dystrophy. And photophobia will be seen in inflammatory conditions. And IOP will be raised in ROP, retinoblastoma, or conditions which have trauma, secondary complications like rubella, and optic disc changes here we have coloboma, physiological cupping, and hypoplasia, or it is systemic cases. So no medications can help at present, and surgery is the primary option for this condition. Next, we have primary open angle glaucoma, so which will be bilateral, and the onset will be in the adult stage and will be characterized by raised intraocular pressure, and angles will be open, and there'll be no secondary causes. In primary open angle glaucoma, we can able to see optic nerve changes and prominent visual field loss. So the risk factors are IOP will be asymmetric of 4 He, and risk factor age is one of the risk factors. So it will be seen in older adults. Race, black are 4 times higher than whites, and family history is also another risk factor. And diabetic mellitus, myopia, and vascular diseases. And patient those who have those who use long-term steroids are also prone to get this primary open angle glaucoma. And this is the pathogenesis. First, the RGP death occurs when pathological event blocks transport of neutrophils from brain to RGC, and this block initiates damage cascade. So, due to these cells are unable to maintain normal function, it undergo apoptosis. So, it also triggers neighboring cells. So, finally, it leads to irreversible cell damage, which are then engulfed by the neighboring cells without inflammatory response. So RGC are associated with the loss of NFL, results in atrophy and irreversible visual field damage, and anterior chamber will be normal. So there will be elevated intraocular pressure, vision would be normal, and at the later stage, RAPD will be seen. So color vision will be affected when optic nerve is involved, and field changes are also will be seen uh, in such condition. So these are the classic signs. So this is the visual field changes seen in the perimetry. So coming to the management part, we have to properly monitor the case, monitor IOL levels and all the vitals too. So we can give medications to reduce IOP levels, and surgery is the primary option, that is trabeculectomy and phacotrabeculectomy. Next is the angle closure glaucoma. So there will be occlusion at a trabecular meshwork by iris, and it is more common and it progresses rapidly. Vision is affected for sure, and here aqueous humor is completely obstructed, and it can be like a pupillary block or non-pupillary block, and also sometimes it is phacomorphic also. So primary angle closure suspect. Gonioscopy shows posterior meshwork in 3 or more quadrants, but not in the PAS. And many patients with less ITZ have evidence of intermittent angle closure. And here there will be normal levels of IOP, and optic disc and visual field. There will be no peripheral anterior synecdoche. So the risk of angle closure glaucoma at 5 years may be around 30%. So in 3 or more quadrants, it be glaucomatous optic neuropathy, and optic nerve damage from an episode of severe IOP elevation, such as acute angle closure, may not appear as typical glaucomatous cupping. So this is the mechanism. The angles will be narrow, so there will be the aqueous will be blocked. So the flow of aqueous will be blocked in this site. The risk factors and symptoms. Age is one of the risk factor, and uh, gender is also another risk factor, and it is uncommon in blacks. Here, narrow angles in the anterior chamber, hyperopia, and it is hereditary. Due to hereditary, also this condition may occur, or due to plateau iris. So in mild cases, there'll be asymptomatic symptoms. So blur vision, it is smoke-filled room will be experienced by the patient. So patient also experiences halo and redness, ocular pain, headache, or any GIT symptoms. So in science, vision is normal unless damage is advanced. So the anterior chamber is usually shallower, and the IOP elevation may be only intermittent. And creeping angle closure is characterized by gradual band-like anterior advance of the apparent insertion of the iris. It may be associated with the formation of discrete um, posterior synecdoche, and individual lesions have having a pyramidal, that is a sawtooth appearance will be seen, and optic nerve signs will be depend on the severity of the condition. So an acute primary angle closure glaucoma, so vision is usually 660 to hand movements. The IOP is usually very high, that is 50 to 100 mmHg, and we can able to see conjunctival hyperemia, corneal epithelial edema. The anterior chamber is shallow, and in the anterior chamber we can also see aqueous flare. So the pupil will be mostly unreactively mid dilated. Vertically oval pupil is classic sign. So the fellow eye typically shows an occludable angle. If not present, secondary causes should be considered. So for this condition, investigation are anterior segment OCT, slit lamp, posterior segment ultrasonography, perimetry, and provocative test. For IOP increase, there'll be subluxation, intraocular surgery, secondary cause, scleritis, and lesions. And treatment, iridotomy, iridoplasty, pilocarp prophylaxis, and lex extraction are one kind of treatment. And similar to PAS, medications also will be administered as a combination. And IV acetazolamide can be administered through IV, and IV and oral medications are also given. Combination therapy steroids can be given. Glycerol indentation and surgery is a choice of treatment for this condition. In secondary glaucoma, it can be pretrabecular, trabecular, and post-trabecular, or with pupillary block or without pupillary block. And a pseudo exfoliation, it is a presence of a pseudo exfoliation material in eye. So this kind of glaucoma, it is rarely seen with less than 50 years of age, and incident of glaucoma will be about 15 to 30%. So it appears as gray white fibrillary amyloid like material. It is derived from the abnormal extracellular matrix metabolism, which in ocular and other tissue. So this get deposited in various ocular structure, and it is also associated with vascular disorder, hearing loss, and Alzheimer. So LOXL1 gene is involved in this condition. So angle closure glaucoma with pseudo exfoliation, it is called capsular glaucoma. So which will be so the IOP will be elevated. There will be trabecular meshwork obstruction, and liberated iris pigments will be seen. So with degenerated outflow dysfunction. So clinical features include pigments in the corneal endothelium, which is Krukenberg spindle, which is a classic sign for pseudo exfoliation, comma. And in the anterior chamber, we can able to see flares. That is the pseudo exfoliative particles. In iris, there will be patchy transillumination defect. And lens, we can able to see deposits and cataract and phacogenesis and Semperlesi line, and the IOP levels will be elevated. So prognosis is worse. Here the prognosis will be worse than angle closure glaucoma. Sorry, open angle glaucoma. So the treatment will be so the medical therapy. Through medical therapy, the condition will be managed. So surgeries include laser trabeculoplasty. So if not, glaucoma drainage device can also be suggested, and trabecular aspiration also. We have pigment dispersion syndrome. So it is liberation of pigments from iris, and it is deposited all over the eye, and it is more common in males. So this glaucoma is associated with the pigment dispersion syndrome if persists over 10 years. So the causes will be a trauma, intraocular tumor, and rubbing off in intraocular pressure. So the pathogenesis would be a pigment shedding precipitated by rubbing on iris, and increases of IOP levels and trabecular meshwork obstruction, and ultimately the glaucoma will be developed. So Krukenberg spindle edema will be rare, and anterior chamber will be deep, and melanin granules will be seen in the aqueous. Iris transillumination effects will be seen, and Semperlesi line on the gonioscopy will also be noticed, and pigments also seen in the lens. So there will be elevated intraocular pressure, which causes glaucoma, and the treatment will be firstly a lifestyle modification. So it is uh, the treatment for open angle glaucoma will be the treatment for this condition also. So laser iridotomy, trabeculoplasty, and filtration surgery will also be performed. And next is the neovascular glaucoma. It occurs with rubiosis iridis, which is the formation of new blood vessels in the iris, where VEGF plays a major role both in retina and also in the anterior chamber. It impairs aqueous outflow and it also elevates IOP levels. The angles are open, causing open angle glaucoma. So, a secondary synecdoche also is also possible here. And causes will be uh, central retinal artery occlusion, central retinal vein occlusion, diabetic mellitus, retinal detachment, vascular diseases, and intraocular tumors. So the symptoms include patient may experience pain, decreased vision, redness, photophobia, and halos. Signs include corneal edema, so the IOP levels will be elevated, and the anterior chamber we can able to see cells and flares, synecdoche, and NVI and NV at angles, and we can also see cataract. There'll be a cupping and high cup disc ratio in the optic disc, which is similar to glaucoma. So, in treatment, close monitoring is very important for patient. So, it is similar to the medication will be similar to open angle glaucoma, and PRP will be suggested, and anti-VEGF treatment should be given, and there will be filtration surgery will perform. If all fails, then an enucleation is the option. And in an inflammatory glaucoma, the IOP levels are elevated, which is secondary to intraocular inflammation. So it is common with uveitis and arthritis. It also shut down the investigation to be shut down to be monitored here. And steroid response are also plays an important role here. And vision decreases, the media will be hazy, and neovascularization and glaucoma may develop, and this can be with or without pupillary block. So, primary open angle glaucoma and closure glaucoma signs are associated, and similar treatments will be followed here. And next is your phacolytic glaucoma, which is related to lens. So it is the secondary open angle glaucoma. It is due to hypermature cataract. So here the trabecular meshwork will be obstructed. So here it is due to leak of lens proteins into the aqueous. So pain, the patient and the signs will be pain will be severe, and there will be decreased vision due to cataract, and slit lamp examination shows corneal edema, cataract, and deep anterior chamber. So, milky appearance will be seen in aqueous, and there'll be pseudo hypopion. So, treatment will be we have to monitor IOP levels first, and we have to remove cataract and protein materials to be washed out from the anterior chamber. Next, the phacomorphic, it is a acute secondary angle closure glaucoma. It is precipitated by the cataract lens, and ligaments and lens move forward, and it blocks the iridolenticular contact. There'll be pupillary block, and iris bombay formation can also be seen here. The signs will be similar to angle closure glaucoma. So the treatment will be similar to acute angle closure glaucoma, and we managed to managed by systemic hyperosmotics also, and cataract surgery and iridotomy are also uh, options for this condition. And next type is traumatic. So it is due to IFEMA post-traumatic. There will be elevated IOP levels. Here, there will be pupillary occlusion by blood clot, and optic disc change will be occur over long term. And patient with sickle cell anemia are at high risk to get this condition. So treatment will be we have to stop anticoagulants, and non-steroidal medication should not be prescribed, and anti-glaucoma medication and atropine can be given. So then further laser photocoagulation and surgical excavation of blood should be followed. by medical therapy, and the patient should be regularly followed up. So in angle recession, there'll be rupture of ciliary body due to blunt trauma. So 10 percentage will develop 10 percentage we develops glaucoma, and irregular ciliary body face is seen on the gonio, and cleft is obscured by fibrosis. Angles are mostly hyperpigmented, and the treatment will be the long-term review and medication to be followed in this patient, and which the treatment will be similar to open angle glaucoma. So laser treatment and filtration shunt are also considered as treatment for this condition. So tonometer, gonioscope, pachymetry, and OCT perimetry are first-line investigations in this. So, pharmacological treatments, prostaglandin analogs, beta blockers, EAI, alpha 2 agonist, miotics, osmotic agents, combination therapy can be given. So, common drugs used are timolol, Lumigan, Treveton, Zepton, and Primodin are given as the pharmacological treatment for this condition. So the surgical management will be RPI, cryoablation, trabeculectomy, trabeculoplasty, and glaucoma drainage device are also uh, um, given for the management, and shunts are also given. These are the pictures: shunt, drainage device for glaucoma. And next is the posterior chamber disease. So posterior uveitis, it is the inflammation of the choroid. It often involves the adjoining retina, forming a chorioretinitis. So the clinical features would be there'll be painless blurring of vision. It will be due to vitreous haze, and photopsia will be noticed. So the flashes of light from retinal irritation. There'll be floaters, the black spots moving in front of the eyes. There'll be metamorphopsia, that is distorted vision due to retinal elevation. There'll be micropsia or macropsia, which is the object appears smaller or larger, and there'll be positive scotoma. It is the fixed dark spot in the visual field. So signs include quiet eye with possible fine keratic precipitates and vitreous opacities, which appears as fine coarse or snowball-like appearance, and active patch appears as a yellowish white thing. An ill-defined lesion will be seen under retinal vessels, and heel patch is the well-defined white area with pigmented borders. So it is further classified as three types: focal choroiditis, multifocal choroiditis, and diffuse choroiditis. Focal choroiditis, here we have single or few localized patches, and in multifocal choroiditis, there will be multiple small patches scattered over choroid, and in diffuse choroiditis, there will be large and spreading of lesions, which will be in which choroid will be involved mostly. So treatment would be systematic, and periocular corticosteroids will be the main treatment for this condition. And posterior subtenon steroid injection will be given for acute cases, and immunosuppressive drugs will be administered if steroids fail in this condition, and there will be specific therapy for underlying cause. So thank you. These are my references.
Thank you so much, Keziya.
Thank you, ma'am.
It was a very nice presentation. Thank you, Keziya. It was a very nice presentation. You covered major contents in a vast manner. Now I request the moderator to add your valuable clinical inputs, ma'am.
Thank you, Keziya. It was a well-structured, very detailed presentation with very good pictures added.
Ma'am, could you
Thank you, ma'am.
loudly, ma'am? Your voice is very soft.
Yes. Am I audible?
Yes, ma'am.
Am I audible now?
Yes, ma'am. It's clear.
You have beautifully covered the anatomy of the anterior chamber, angles, posterior chamber, and covered a lot of diseases, different types of glaucoma. Uh, I just wanted to add a few points that it is a very clinically relevant topic, I think, because Keziya, do you know which technique we use to assess the depth of anterior chamber?
Gonioscope, ma'am.
Depth of anterior chamber depth. Which technique you use in slit lamp?
Van Eyck grading, ma'am.
Van Herrick grading we use. Okay, if in Van Herrick grading, if we detect a shallow anterior chamber, we will do gonioscopy, right? So I think
Yes, ma'am.
gonioscopy is a very good skill or an important skill every optometrist should practice. And while we examine a patient clinically, it is very, very important in detecting the anterior chamber depth because um, we can refer the patient for or we can do a gonioscopy and we can detect early risk of acute angle closure and as you discussed the different types of glaucoma like pseudo exfoliative glaucoma, pigment dispersion syndrome. um, do you know what are the indications for doing gonioscopy? Can you tell me some of the indications, Kesia?
For angle closure glaucoma, ma'am.
Then, okay.
Posterior synecdoche.
Yeah. Okay. So I think while doing uh, while attending patients clinically, I think we should know the indications for gonioscopy. Like the few indications for gonioscopy include you told in detail in your slides about Krukenberg spindle. When there is pseudo exfoliation, when we see a shallow anterior chamber, then in case of blunt trauma, to rule out angle recession. Uh, in when we see in slit lamp these all findings and also rubiosis iridis to rule out neovascular glaucoma. Okay, so these all conditions we can do a gonioscopy to detect uh, the different types of glaucoma and also we can be on safer side whether we can decide to dilate the patient or not. It is better to do a gonioscopy. That's all from my side. It was a very good presentation, very detailed one. Thank you.
Thank you so much, ma'am. To know about angles and glaucoma itself is a big ocean. So, for the students, from your inputs, like clinically, what are they missing out in OP findings, or how should be aware about checking angles? When should they dilate? Is there any key points which you have to add to tell students in this perspective, ma'am?
Yes. When we examine in slit lamp, I think we should the mostly the things we miss usually include neovascularization. Usually we will miss. Then pseudo exfoliation will miss, and we will usually miss the Krukenberg spindle. We will have a doubt whether it is pigment dispersed or Krukenberg spindle. In that case, I think it is better to do a gonioscopy to rule out the pigment dispersion syndrome.
Thank you so much, ma'am. Thank you, ma'am, and thank you, Kezia. It was a very vast presentation. And as of now, we don't have any other questions, ma'am. So, over to Gomati now.
Thank you so much, Meenakshi. Keziya, best wishes. It's a wonderful presentation. And Susan, ma'am, thank you so much for joining with us today, ma'am. We would like to host you on another wonderful platform in the future, ma'am.
Thank you. I would like to thank Dr. Agarwal's Institute of Optometry, Annshaebano, and the whole team for giving me the opportunity for moderating the session. It was a new experience for me. Thank you very much.
Thank you so much, ma'am. Dear audience, thank you all for your continuous support towards Optometry series. If you like this video, give a thumbs up and share with all your friends. The announcement for this particular week is ISV Tech. The collaborative conference with Loyola ICOM College of Engineering and Technology is happening next week, 24th and 25th October. And this time we have introduced few seats for the standalone workshops alone. The registration details and all the links will be provided in the description box. So please check it out and register for the conference. Let's all meet over there. So until then, tata, bye bye. We'll meet in the next episode. Thank you so much, Susan ma'am. Bye, ma'am.
Thank you,
Thank
ma'am.
you, team. Thank you, team. Thank you, Meenakshi. Thank